talk to us about IVC thrombus.
Good afternoon. I think we bring Brexit to be over. Ladies and gentlemen, it's really an honor to be invited by the organizers here, ASVS 26th. And I remember it was 2016 when the ASVS again NAVF took place here, and was also part of that. And this time it's all the more vibrant, as I can see that. So I am really happy to be back in this wonderful place with my Bangladesh colleagues. We have a team of 6 here sitting right in front of me. So fantastic atmosphere. Today I'll be sharing my experience with, or team experience rather, with IVC tumor thrombus. A bit of initial experience, I should say, because we have not been working on IVC on a very regular basis. So this is a flashback on the ASVS meetings. You can see colleagues here. I think Stephen also there. I think it's photograph, right? So from Indonesia, from Bangkok, and all other places. Last ASVS took place in Bangkok, and it's really fresh in memory. And this is where I'm from, Bangladesh. Very typically described as a green country. It is a green country. And don't forget to consider this man. You can see a green man as well. So some of the monumental things there, the National Mausoleum, the National Parliament buildings right here, and the village area, the rural Bangladesh, very green. So these are 2 hospitals where I work. The National Institute of Cardiovascular Diseases, Dhaka. It is described as the, parent institute for cardiac and vascular diseases and all those things. And on the right-hand side, the Bangladesh Specialty Hospital is one of the new initiatives in the private sector, where I also work. So I'm not going to disclose. That brings us to our topic today. So, as I said, surgically working on the IVC has been a relatively recent thing for us. We have not been consistently working on this. So I'll be telling you about my recent experiences on 7 cases, and we'll be showing a few of the glimpses, and also the surgically created portosystemic shunts. Now that area we have been stepping in recently. So the case one, a young lady, I remember, I actually saw her in the operation theater for the first time because I was called in by a general hepatobiliary surgeon who was operating on her, and the tumor that was there sitting on the IVC was already resected, mostly. A small 10% of the tumor cell was left behind. It was asking my opinion about it, what to do about it. Resect there and reconstruct the IVC. I said, okay, I'm not ready for it. My team is not with me. And so it was something that I also decided, okay, probably I should be leaving it behind for now. So that lady was followed up, and she came back to my place, to my chamber 2 years down the line. And then we rather figured out that the tumor had grown back significantly. So we had to plan it out. And we did so, and operated on her again. And the complaint that she was having was abdominal pain radiating to the back and all those things. And so the first diagnosis was low-grade luminous sarcoma. That's what it was. And this is what it was. So the second time around, we had to completely resect out the tumor. And that took out a part of the entry wall of the IVC and left inner vein as well. So we needed to reconstruct, and that's what we did with the big dacron patch, as you can see. And the lady did well, actually did not come back to me ever again. So she's unfollowed. Second was the right renal cell carcinoma right-sided, and we had to get together a team of urologists and vascular surgeons, of course. And then we did it at NICVD, I remember. The nephrectomy was done by the urologist, and the mobilization of the liver to expose the whole length of IVC was done by the general surgeon, I remember. And this is what it looked like. The nephrectomy has been done, and we opened the IVC, having taken control proximally and distally. And fortunately, the tumor thrombus was very organized and came as a chunk very well. And we checked the retrograde flow from the right atrium in the very strong gush of blood. Then we repaired the IVC directly. and that's how it looks like. The case 3, left-sided renal circulation. This was one a bit advanced and extended proximally almost up to the right atrium. So we had to involve the cardiac surgeons in this particular case. And as you know, the classifications, as it keeps going up, the complexities tend to increase. So we decided that, okay, cardiac surgeons will be stepping in. It was 3D, so they decided to do it using a cavo-atrial bypass. That's exactly what they did. And then open the IVC. It looks like that, and come back to me, and okay. And then the reconstruction was done directly, as in the past case. Okay, having said that, this is our experience with the portocable shunt that we created in this particular young lady who required more than 100 units of transfusion in the past 1 year. So we were called in, the National Gastro-Liver Institute, so we, the vascular team went in. We had this plan of doing the portocable shunt. And as I hear, it worked wonderfully well for her. She did not require any transfusion ever since. So these are the challenges, as you all know, because you know, in this era of endovascular intervention, surgery, well, is being, you know, taking a backseat. I'm not sure in many cases, but of course we should not be forgetting surgery. And working on the IVC has its own challenges. And I remember that working on the IVC, especially proximal IVC, you have to really be ready for significant bleeding, and you have to be ready for transfusions, all those things, keeping an eye on the hemodynamics, involve anesthesiologists to do the needful, and planning preoperatively who are the guys being on the team, who are the people you need in the team, so that has to be decided. So if you talk about the multidisciplinary approach, that's the best thing to have you be done with safety. So this is what it is. So I think our initial experiences would really say that this is something that will be required when you think about the renal cell carcinomas, all other malignancies. From time to time, it will be needed to be done. So I think vascular surgeons need to be ready for all those things as well. Sometimes you are called in immediately without any preparation. So those are the bailout situations. You have to respond to that as well. But on many occasions, you really have to plan the procedures before you really step in. So this is the Bangladesh Vascular Society. It's a small society. And I'm the current president. My GS is here also, General Secretary is sitting in front of me. And this is a part of the surgical, the members of the society. And our journal is already coming out, so we have 2 issues, so far third one is coming. So I seek your support and contribution for this particular journal so that we can keep going. I personally edit the journal, so I really seek that you come up and help us. We had our third interest conference last year, 2024, and as many as 16 international faculties came in and joined us. So we are planning the fourth one in coming December or in January. So please do come and join us. So 6 of us have come in, today in this conference. Dr. Jubai, Dr. Rakibul, Dr. Saklain, Professor Niyaz Chaudhary, and Dr. Shantun is yet to come. So we really look forward to build bridges among the different societies. Of course, we want to connect with ASVS and all other international vascular forums. Thanks again for your invitation, and we really look forward to be with you in the future as well. Thank you.
Right. Next, I would like to ask